Short presentation on a small research project to determine accuracy of CT in renal sinus fat and calyceal involvement patient with clear cell renal cell carcinoma. Clear cell renal cell carcinoma is the most common subtype of renal cell carcinoma. It has been quite difficult for us to determine on CT the invasion of renal sinus fat or renal calyx, which constitute T3 tumor, along with perinephric fat invasion and also renal venous tumor thrombus. T1 or T2 tumors are those confined just to the renal parenchyma. T3 tumors, one subset of them, are those which actually invade the renal sinus fat and renal calyx. Now, why is this important? Because there might be surgical complexity, particularly when partial nephrectomy is being considered. So our aim was to see if we could accurately predict renal sinus fat and create some kind of scoring system which might help us predict renal sinus fat and renal calyceal involvement. So we devised a very simple scoring system and to kind of test this hypothesis. So our patient or study population were patients with clear cell renal cell carcinoma who underwent radical nephrectomy, who also had a dedicated renal protocol CT scan in our institution between the times of 2008 and 2009. Renal protocol CT in our institution includes thin slice CT scans with corticomedullary and nephrographic and excretory phase images. All these studies were read by two experienced uroradiologists independently, and the imaging was reconstructed in multiple angles when necessary. So our scoring system was pretty simple. We assigned a score of 1 to 4. 1 is not involved, 4 is clearly invade the renal sinus fat or renal calyx. The scoring system is very similar: not involved, abuts and distorts, and clearly invades. So here are some examples. This is an example of a tumor which does not involve the renal sinus fat. This is an example of a tumor which actually abuts the renal sinus fat, but there is no distortion of the renal sinus fat. On the other hand, this is a tumor which not only abuts but also distorts the renal sinus fat. This is an axial image. This is a multiplanar reconstructed image here. This is an example of a tumor which clearly invades the renal sinus fat. Similar scoring system in renal calyx. Tumor does not involve. Here the tumor abuts the renal calyx. Tumor abuts and distorts the renal calyx. Tumor clearly invades the renal calyx. We compared these to the pathology results which were available. A total of 65 patients for renal sinus fat scoring and 63 patients for renal calyceal scoring. So when it comes to renal sinus fat involvement, this was the spread. 1 out of 65 did not have any involvement, 7 abuts, 24 distorts, 33 with a score 4. On pathology, we found that there was no invasion in the patient who had no involvement. 1 out of 7 had involvement of the renal sinus fat who had abutment. 6 out of 24 with distortion had invasion, or 18 out of 24 who had distortion of renal sinus fat did not have invasion, and 30 out of 33 who had appearance suggestive of clear invasion had actual pathological involvement as well. So if we consider scores 1 and 2 as negative, that gives us a sensitivity of 97%, specificity of 25%. So on the other hand, with pelvic calyceal involvement, there was no involvement on pathology on those patients or on those studies which were deemed not involved or abuts, whereas on those which had distortion and invasion, these were the only one patient had invasion when there was distortion, and 5 out of 17 had invasion when there was appearance suggestive of direct invasion. So the sensitivity, if a negative predictive value, is almost 100% with pelvic LACL involvement. So the possible limitations of this study. There is some difficulty that we encountered when assigning scores of 3 versus score 4, that is distortion versus direct invasion. And this requires some care. You need to have multiplanar reprocessing, not just in straight sagittal and coronal sequences, but also sometimes along the axial or along the plane of the kidney. There is also a selection bias in our study. We only selected those patients who underwent radical nephrectomy, i.e. those patients who we thought had more advanced disease. But that is probably the strength of the study as well. Involving a lot of partial nephrectomy would have diluted or skewed our population to the left. And only clear cell renal cell carcinoma was included, as we all know that the biology of these renal cell carcinoma subtypes are different. So we thought that what is true for clear cell carcinoma may not be applicable for other subtypes, and those may require further individualized studies. So in conclusion, CT has high sensitivity but low specificity when scores 1 and 2 are considered negative.